Good afternoon, everybody. Thanks for joining us today in our cardiovascular grand rounds. Welcome, Dr. Pollak, and thank you for being with us today. My name is Lorena Telles. I work at La Cardio, and it's my pleasure to introduce to you to our moderators for this event. Dr. Carlos Ortiz, clinical cardiologist, and Dr. Héctor Medina, director of the cardiovascular imaging at La Cardio. Welcome, and thank you for moderating this event.
Buenas tardes a todos. Muchas gracias por su participación. Mi nombre es Carlos Ortiz, soy cardiólogo clínico y estoy en compañía del doctor Héctor Medina moderando esta conferencia. Les recordamos a todos que al conectarse a esta conferencia autorizan el tratamiento de los datos personales, los cuales están de acuerdo con la ley 1581 del 2012 y nuestra política de datos personales, que la pueden consultar en www.cardioinfantil.org. El chat de preguntas en este momento se encuentra habilitado en la barra de participantes. Les agradecemos allí dejar todas las inquietudes que vamos a resolver en el final de la sección. Tenemos un agradecimiento especial por la empresa Safred, porque se vincula como patrocinador exclusivo de esta actividad. Y muchas gracias, doctora Pollak, por estar con nosotros.
Bueno, hoy tenemos el gusto y el honor de tener a la doctora Pollak compartiendo su conocimiento aquí en la Fundación Cardioinfantil. La doctora Amy Pollak nos va a dar la conferencia, tal y como lo decían ahí, Tips and Tricks for Adhering with Hypertension Guidelines in the Real World. Ella fue a Colegio de Medicina en la Universidad de Virginia, se siguió de un Master's de Clinical Research en la Universidad de Virginia, fue jefe de residentes en la misma universidad e hizo Fellowship de Cardiovascular de Cardiología y imágenes cardíacas en la Universidad de Virginia también. En este momento ya está adscrita a la División Cardiovascular de la Clínica Mayo en Jacksonville, Florida, y también es la directora del Centro de Corazón para las Mujeres en la misma institución. Está Board Certified en cardiología, en ecocardiografía, en tomografía computarizada de corazón y en cardiología nuclear. Welcome, Dr. Pollak. You may start, and as mentioned before, it's an honor to have you here. Thank you so much, and the podium is yours.
Oh, muchísimas gracias, Dr. Medina y Dr. Ortiz, por la invitación a estar aquí con ustedes hoy. Ojalá que tenemos la oportunidad de estar juntos en persona otra vez. But I'm going to speak in English for this presentation because it's much más fácil for me and when talking about medicine. But I would love the opportunity to speak Spanish and spend time with you all at a future time. So thank you for the tremendous honor to be with you today. I am really excited about the topic of hypertension because this is something that certainly is a key part of everyone's practice in cardiology as well as in internal medicine and family medicine. And so we'll go through some tips and tricks for my approach for treatment of hypertension. I have no disclosures, and I'm just going to minimize this Zoom panel here. So the three learning objectives are to first review the management of hypertension using the framework of the ASCVD risk stratification. Second is to understand what's new in hypertension management, and then to use that information to explore the treatment of resistant and refractory hypertension. So we'll start with the stages of hypertension and when to treat based on somebody's atherosclerotic risk. Then we'll move to diet and lifestyle, and then end with that resistant and refractory hypertension. All right, so our most up-to-date guidelines where we really are integrating patients' cardiovascular risk with how to manage their blood pressure really goes back several years to 2017. And this was really a key turning point in terms of what cut points we used to define hypertension. You can see here in green, a normal blood pressure has always been less than 120/80 and certainly continues to be that. That essentially systolic blood pressure in the 120s with still a diastolic less than 80 is considered elevated, kind of that pre-hypertension. And then stage 1 hypertension was redefined really to be a systolic blood pressure in the 130s and then diastolic in the 80s. And then stage 2 hypertension was really with that systolic pressure greater than 140 and diastolic pressure greater than 90. So if this is our framework, we'll look then at why are we so worried about diastolic pressure, systolic pressure, or both? And I feel like this topic comes up in studies over the years. And I think the best data that I've seen is that both systolic hypertension as well as diastolic hypertension both independently increase the risk of MI or stroke. So I certainly look carefully at patients who have isolated diastolic hypertension, and you'll see that regardless of which definition of hypertension, the stage 2 here in red or stage 1, blood pressures in either of those ranges are associated with an increased risk of cardiovascular events. Well, as we're thinking about defining hypertension and when to treat, we really need to consider white coat hypertension or clinic-based hypertension. And this is when patients are reporting normal blood pressures at home. And in the office, the blood pressures are somewhere in the 130s to 150s over 80s to 90s. And that's a pretty big spread. If the office blood pressure is 160 or higher, that's really not going to be white coat hypertension. And I would challenge that maybe the patient's blood pressure readings aren't completely normal at home. But assuming that somebody's blood pressure really is in the 130 to 150s in the office, and they're reporting completely normal blood pressures at home, it is absolutely reasonable to screen for white coat hypertension. And that white coat hypertension will be found in about 20 to 30% of the individuals that we were just describing. It can be helpful to do an ambulatory blood pressure monitor, one that patients wear, whether or not it's for 6 hours or for 24 hours, to be able to get enough of a time spread to understand if somebody's blood pressure is really in a normal range in their home environment, or if there are periods where it really is going up. It can also just be done with checking blood pressure readings with a cuff after you've given them good instructions for how to do that, ensuring their cuff is the right size for their arm. And if somebody's blood pressure at home really is normal, then they have a good prognosis. If somebody's blood pressure is really high and it was elevated in the office because of stress, and then it's elevated at home under periods of stress, well, then we have our answer and it's hypertension and we need to treat accordingly. So first step really is making sure there's no white coat hypertension if individuals are reporting normal blood pressure at home. So I just outlined those options of the home monitoring, the 6-hour test, or that 24-hour test. I find that 24-hour test is the most useful if I'm having patients report some blood pressures that were normal in the morning, but elevations later in the day, or conversely, fairly normal blood pressures in the afternoon. And when then they're waking up first thing in the morning, the blood pressure is high. And then as we start to move towards treatment timelines and decision trees, I just wanted to highlight some of the important characteristics of the SPRINT trial. And I know that folks on this call are very familiar with the SPRINT trial design, but I wanted just to highlight and remind us that the SPRINT trial excluded patients with diabetes or a history of stroke. So as we're applying the recommendations from this more stringent approach to blood pressure control, keeping in mind that these patients, diabetics and those with prior stroke, were not enrolled in the SPRINT trial. The population that was studied, however, were individuals over age 50, systolic blood pressure 130 to 180, and they had to have some degree of increased cardiovascular risk, whether or not it was subclinical disease, chronic kidney disease, or elevated Framingham risk. And as you know, they were randomized to the 2 arms of that intensive blood pressure, and the goal really aimed to be less than 120. and the standard blood pressure. And that's where the goal was less than 140. And medications were titrated to keep that blood pressure essentially in the 135 to 139 range. So the outcome, it was a composite outcome of MI, acute coronary syndrome, stroke, cardiovascular death, and heart failure. And as you recall, they found that the mean blood pressure in that intensive arm was certainly lower, 121, compared to the blood pressure of 136 in the standard arm. In order to get that lower blood pressure, individuals were on one additional medication on average in the intensive arm compared to that standard blood pressure arm. And there was a reduction in that primary outcome for that intensive arm. So you can see that that absolute risk reduction between 1.7% versus 2.2% is fairly small. The relative risk reduction certainly looks more striking, but nonetheless, on a population-based perspective, we were able to show a decrease in cardiovascular events with that more intensive blood pressure lowering. There was also a mortality benefit. You can see here with a hazard ratio of 0.73. Keep in mind that the benefit of the decrease in events and the reduced mortality not only came at a cost of taking one medication on average extra than the standard blood pressure arm, but also higher rates of hypotension, of syncope, of electrolyte abnormalities, and acute kidney injury. So this is certainly an approach that needs to be individualized to that patient in front of us, as I know that we all do with patient-centered medications and approach to treatment. I thought this was a really interesting subset of the SPRINT trial that was published in 2019, and it looked at, in that intensive blood pressure arm, again, that average blood pressure of 120 essentially, they found that there was a 19% reduction in all-cause mild cognitive impairment for that intensive blood pressure control. And we know that mild cognitive impairment can certainly progress to dementia. So we were seeing a potential for having an impact on reducing cognitive impairment, and therefore by extension, potentially having an impact on dementia by that more intensive blood pressure control. So then how do we decide who we're going to be treating to which blood pressure goals? So the 2017 AHA guidelines support this following approach. If somebody has a completely normal blood pressure, we're certainly still recommending optimal lifestyle, regular exercise, low sodium diet, Mediterranean diet, maintaining normal body weight. If somebody has an elevated blood pressure here in blue, we're kind of counseling them that they're on that cusp of developing hypertension. So really in that pre-hypertension category. And we're really giving that strong recommendation for lifestyle modifications and then reassessing their blood pressure in the next 3 to 6 months. For that stage 1 hypertension, this is where we're looking at somebody's cardiovascular risk. So if somebody has evidence of cardiovascular disease, so clinical atherosclerotic cardiovascular disease, so prior history of cardiac disease, of stroke, or if there's a risk, that ASCVD risk score using the pooled cohort equations of greater than 10% over the next 10 years, if the answer is yes, then we're going to be treating them with not only lifestyle, but also starting antihypertensive therapy. If someone does not have a history of cardiovascular disease and their risk is less than 10% over the next 10 years, they're in a lower risk category, and we can not go straight to medications with diet and lifestyle, but rather just focus on those lifestyle changes and reassess. In this red category for the stage 2 hypertension, or the greater than 140 over 90, this is where everyone will agree this is clear-cut hypertension using lifestyle as well as starting medication therapy. And I think this is something that this group is probably very aware of as well. The 2020 International Society of Hypertension published the Global Hypertension Practice Guidelines. And from a global population perspective, because of that, the cost of taking more medications, as well as the risk of potential side effects with that much more intensive blood pressure lowering, kind of that overall threshold for when to start medications was recommended to be 140/90, with the important caveat that for patients at high cardiovascular risk or who have known cardiovascular disease, that we treat with medications for that blood pressure of 130/80. So that is still certainly aligned with those 2017 AHA-ACC guidelines. So in terms of that approach to hypertension, that first step, we excluded white coat hypertension. Second step is to use that ASCVD risk, or basically does somebody have known cardiovascular disease wherein it's secondary prevention, or are they at a high enough cardiovascular risk with a 10-year risk or more than 10% for primary prevention, where we're going to go ahead and treat with a blood pressure of more than 130/80, serving as that trigger to use medication in addition to lifestyle changes. And then if somebody is not at that higher cardiovascular risk, their risk score is less than 10%, primary prevention, then we're not going to treat with medications until their blood pressure is more than 140/90. And I think this is an important caveat that I just highlighted here. For older adults, and certainly this is not a one-size-fits-all definition for older adults, but I think for me personally, as we get into our 80s and beyond, the ASCVD risk score is going to fall into that higher risk category. And so I think we really need to look closely at what is that patient's burden of comorbidity, what is their life expectancy, and really have that underscoring of the importance of a patient-centered decision-making, because I don't think that all patients should be treated to a systolic blood pressure in the 120s, particularly if they are and they're 85 years old and had a history of orthostatic symptoms or fall risk. And that really is where we need to individualize it regarding how intensively do we aim to try to drive someone's blood pressure down. And I don't know about you all, but certainly with COVID, we've done more telemedicine, and there's certainly some great advantages to that and disadvantages, as I think we all would agree. But I thought this was a helpful review published in Hypertension last fall, and essentially for how to integrate telemedicine for the management of hypertension, we are encouraged to have proactive follow-up and to have somebody in your practice be that case manager to really facilitate that data exchange where patients are sending in blood pressure readings. That case manager, whether or not it's a nurse practitioner, physician, is integrating that information and then having follow-up back to the patient, whether or not it's through a patient portal, through the medical record system, through text messaging or video consultation. And as part of that, integrating opportunities to provide education about the management of hypertension, as well as reinforcing those diet and lifestyle changes. So with that, I'd like to move to that diet and lifestyle approach to hypertension. I put this slide here. I love going to Alaska in the United States, and thankfully, this is not a picture of me or anyone in my family, but seeing this picture, this would definitely give me stress, and my adrenaline level would be going up. I'm sure my blood pressure would be going up, and that fight or flight response is certainly appropriate in this situation. But I think that problem, that chronic stress, it's more of this tornado. And certainly we've been in unprecedented times, both as healthcare providers, as well as just global citizens of this community across the world. And that stress certainly can have an impact on blood pressure, as well as on patients' decisions towards healthy eating and continuing with exercise habits. And so certainly no one has that magic recipe to eliminate stress, but I do think it's critical that as providers, we talk with our patients about their strategies for dealing with the stressors that are in their life and the impact it can have on their blood pressure, whether that's meditation, talking with family or friends, that regular exercise, but just highlighting that stress management is an important part of how we need to be approaching hypertension as well. Those traditional lifestyle changes, weight loss absolutely is important. You can see there's about a 1 millimeter of mercury decrease with a kilogram of weight loss. So although weight loss is absolutely important, I encourage patients that they can make a big impact on their blood pressure by what they're eating and how active they are. And this is really highlighting with this DASH eating plan. And that's a pretty dramatic lowering in blood pressure just by adopting those dietary changes. Physical activity, only having moderate alcohol use and not more, and then avoiding NSAIDs absolutely are key lifestyle changes for blood pressure. I want to talk more about the salt sensitivity, and I'm sure this is a topic that you all are very familiar with, but I find it that I talk about this with my patients really every day, because there is this impressive relationship to me with salt sensitivity in certain populations. Absolutely, those that have hypertension tend to be more salt sensitive as we get older, over age 45. Individuals who have metabolic syndrome, not Hispanic Blacks, and then women tend to be more salt sensitive. So what does that mean? This is a great scientific statement from a couple years ago at this point in 2016, but it looks at the change in average blood pressure by age group. So in your 20s and 30s, going into your 40s, 50s, and 60s across the screen. And you can see whether or not you're normotensive in green or hypertensive in blue by having a salt-restricted diet. You can have a pretty dramatic impact on blood pressure, most dramatic, certainly for those that are hypertensive in their 40s and beyond, but even for individuals that are younger and hypertensive. And so I think this really underscores that critical importance of taking a hard look at the sources of sodium in your diet. And I'm sure, like many of you, I share personal anecdotes with my patients, and we eat a low sodium diet in my home. My husband's also a cardiologist. We have 2 children, and there are things that even surprise me. We love eating pretty much anything with black beans, and I've learned to make my own black beans to avoid the canned issues or finding ones with no salt. And we transitioned to making our own tortillas because the prepackaged ones have really a pretty impressive amount, 300 milligrams of sodium for just a small tortilla that we have in our grocery stores. And certain marinades that I would use in the past, taking a second look to say, wow, that is really high in sodium. And so there are many sources of that hidden sodium in diet for patients, including me being fooled by some. And so I really highlight this with my patients because it can make such an impact on blood pressure. Sleep apnea is another treatable cause of potentially reversible cause that impacts hypertension. And we know that there's a variable degree of blood pressure lowering when individuals have sleep apnea and hypertension, can be up to 10 millimeters of mercury. For those patients who complain of blood pressure that's high first thing in the morning, it's normal in the evening, they wake up and it's high in the morning, that nocturnal hypertension, I'm definitely concerned about sleep apnea and wanting to potentially do an overnight pulse oximetry to screen for this as part of the management of their hypertension. We know that treating sleep apnea can have a more significant response the more severe the sleep apnea is, if someone's on medications for hypertension, or if they have resistant hypertension. So we'll move into this resistant and refractory hypertension and spend the bulk of our time there, because I found that those initial recommendations for which antihypertensive to use for kind of uncomplicated stage 1 or stage 2 hypertension, folks are so savvy and so good at that. And I'm hoping that I can provide some insights that will help you in your clinical practice with this resistant and refractory hypertension. So I see resistant hypertension a lot in our practice. There are 2 different definitions. They are very similar, but I'll just highlight that the JNC-7 definition was hypertension in patients who are compliant with 3 medications, including a diuretic. And of course, we want these medications to be at or near their maximal doses. And then to the right here in yellow, the AHA scientific statement said uncontrolled blood pressure despite 3 medications, or blood pressure controlled, but requiring at least 4 medications. And I think that the key take home to the resistant is that you really want patients to be on 3 medications, including a diuretic, and have uncontrolled blood pressure. Therefore, if you're controlling it on the 4th one, you're getting controlled resistant hypertension. So 3 medications, uncontrolled hypertension, one of those medications is a diuretic. You therefore have defined resistant hypertension. And that's important because it serves as a trigger to those causes of resistant hypertension that I would encourage us to make sure we've gone through in our differential, as well as a treatment strategy that helps improve the management of resistant hypertension. So the actual prevalence of true resistant hypertension is unknown. There's estimates that it may be approaching 9% of US adults with hypertension. Smaller studies suggested it may be lower than that, 2%. I think in my practice, it's at least 10%, if not more. We know that resistant hypertension is associated with that higher risk of cardiovascular morbidity, stroke, and heart failure. And it's important when you have somebody with uncontrolled blood pressure on 3 medications, including a diuretic, to identify first and foremost, is this a pseudo-resistant hypertension? Is it in part related to an improper blood pressure measurement? Is it that white coat effect that's compounding the management of their hypertension? Or is there really poor medication compliance? Because that happens so often in all of our practices. And really, half of those uncontrolled blood pressures will really be due to true resistant hypertension. And the causes of resistant hypertension, I'm kind of hearkening back to that excess sodium intake. As a corollary to that, inadequate diuretic therapy potentially is related to medication dose or side effect, excessive alcohol use, and then those secondary causes of hypertension. So we'll highlight those. In terms of medication side effects, this is the list that I have going through my mind as I'm seeing patients with resistant hypertension. Are they on NSAIDs or COX-2 inhibitors? And sometimes patients have enough of an inflammatory condition or bad enough arthritis that they need to be on a low dose NSAIDs or COX-2 inhibitors. But often we can navigate patients away from the NSAIDs, particularly if it's having an impact on blood pressure. For women, oral contraceptives can certainly be associated with an increase in blood pressure, predominantly in the estrogen forms of contraceptives. And in half of the women who have hypertension on oral contraceptives, you stop the hormone therapy and the blood pressure returns to normal in half. The other half probably really had underlying hypertension that was just making it worse with the contraceptives. Certainly always asking about the sympathomimetics, so decongestants, diet pills, cocaine, other stimulants like amphetamines or methylphenidate. We talked about that, the impact of alcohol on blood pressure. Antidepressants certainly can have a role in increasing blood pressure. Things like venlafaxine can have a role in blood pressure. If patients are receiving erythropoietin or they're on cyclosporine, and then certain herbal compounds that can impact blood pressure. So I go through that list in my mind of what are the medications that could be confounding it, making sure that these are not an impact for the patient that I'm seeing. And then before we go into that algorithm for resistant hypertension, I'd like to just highlight that refractory hypertension is inadequately controlled blood pressure despite 5 or more medications, including the diuretic chlorthalidone, as well as spironolactone. And thankfully, resistant hypertension is much more common than refractory hypertension is. Refractory hypertension can be so challenging to treat, and it occurs about 3% of the time with resistant hypertension. So oftentimes I'll have patients tell me, well, I have had hypertension, I'm on 3 medications, 4 medications, doesn't matter what I take for sodium in my diet. And it does. This was an interesting study that looked at having sodium intake less than 1.1 grams per day in resistant hypertension, and you can see a really profound lowering of blood pressure still in these patients. Not enough to make it so that way they don't need antihypertensive therapy, but it certainly can be a critical part of management of their hypertension. Likewise, with exercise, treadmill walking 3 times a week for 8 weeks was associated with a lowering of blood pressure by about 6 millimeters of mercury systolic for patients with resistant hypertension. So in terms of a treatment approach to resistant hypertension, there is a large laundry list of medications that we have at our disposal. And I'd like to propose a 3-step approach. As we go through the 3 steps, I wanted to highlight that as we get to step 2, which involves the ACE or ARB in combination with a calcium channel blocker, to highlight that dosing it twice a day, even if it was on the prescription information as a once daily drug, can certainly help to maximize the effect. And I'm always amazed about what an impact that can have with the twice daily dosing of the ACE, ARB, or the long-acting calcium channel blocker. So we'll go through a 3-step approach. All right, the first step for treatment of resistant hypertension is to optimize the diuretics. And I think everyone here is very familiar. We have in our toolkit the thiazide-like medications like chlorthalidone, and then the loop diuretics. So certainly if somebody has significant kidney dysfunction with a GFR less than 30, they're not really going to respond to the thiazide or the thiazide-like diuretic with a significant impact on their volume retention, on their sodium, and on their blood pressure. And that's really where we need to have them on a loop diuretic. I'd also like to highlight that chlorthalidone is twice as potent as hydrochlorothiazide. So for patients with resistant hypertension, I'm not using hydrochlorothiazide, but rather transitioning to chlorthalidone instead. And also keeping in mind that the thiazide and thiazide-like diuretic medications can cause a dyslipidemia, particularly related to triglycerides. So it's something that we just need to be on the lookout for as we're following our patients for their lipids, as well as for their hypertension. All right, so first step is optimizing diuretics, remembering that role of chlorthalidone, or if they have a GFR, glomerular filtration rate less than 30, using a loop diuretic. So the second step is optimizing the ACE or the ARB, but doing one of those with the calcium channel blocker. And this, I was impressed that the data supports that an ACE and a calcium channel blocker together are superior in terms of the impact on blood pressure lowering when compared to just using an ACE and a thiazide alone. And an ARB and a calcium channel blocker together will control blood pressure in about 60% of individuals who had been on a 3 medication regimen, including a diuretic. So there's this very synergistic relationship between either an ACE or an ARB along with that calcium channel blocker. So we've layered on the diuretic, ACE or ARB, and then the calcium channel blocker. And then the third step is really the mineralocorticoid antagonists. So spironolactone or eplerenone. And you certainly have to look out for somebody's potassium and their GFR. So generally speaking, if their glomerular filtration rate is above 45 and their potassium is in a normal range, then it's going to be safe to layer the spironolactone or the eplerenone with the ACE or the ARB. There's certainly that risk of hyperkalemia, and we need to monitor these patients. And then just keeping in mind that those breast symptoms, gynecomastia and breast tenderness, are dose dependent and certainly can happen to men or women. It doesn't happen commonly, thankfully, but it's something that I like to talk to my patients about, just so that way they're aware and can alert me if they're having any of those side effects. So why is the spironolactone such an important medication to add? It's our third step, but it's really the fourth medication, since we had a diuretic, ACE or ARB, the calcium channel blocker, and then the spironolactone as that fourth medication. And this is from the ASCOT trial. And you can see that in patients who had spironolactone added as that fourth medication for resistant hypertension, that there was a significant lowering in blood pressure. So systolic blood pressure went down by almost 22 points, and diastolic blood pressure went down by a little under 10 points. That's a big impact for these patients who have resistant hypertension. I mentioned, kind of circling back to those secondary causes for uncontrolled hypertension, or certainly in certain populations who have new onset hypertension, we need to screen and evaluate for secondary hypertension. So drug-resistant or drug-induced hypertension, we're thinking about these secondary causes, a real abrupt onset of hypertension in patients without any established risk factors, definitely are going to be one to screen for secondary hypertension. If somebody's quite young, under age 30, wanting to look for secondary hypertension, this accelerated or malignant hypertension, if it's isolated diastolic hypertension in adults without any other established cardiovascular risk factors, or certainly if you're getting that clue, then there may be something wrong with the aldosterone axis if patients have unprovoked or excessive hypokalemia. So we can find secondary causes for new or uncontrolled hypertension in 10% of the time. So we end up looking for it a lot, don't always find it, but these are the populations where we want to go ahead and to do that evaluation. So the major causes of resistant hypertension due to secondary hypertension causes would be, the big three are sleep apnea, primary hyperaldosteronism, and then renal artery stenosis. You can see that underlying chronic kidney disease, drug-induced or alcohol-related, thyroid and pheochromocytoma certainly round out the list, but are much less common. And so I wanted just to highlight the primary hyperaldosterone, because this is something that is really in that intersection between what we see in cardiology, what our colleagues in endocrinology and other hypertension specialists see as well. So there's a confirmatory saline suppression test that can be done 2 to 3 weeks after stopping diuretics and ACE, ARB, and a month after stopping a mineralocorticoid receptor antagonist like spironolactone or eplerenone. And we're looking for a high aldosterone level. Then that would tell us we either are worried about an adrenal adenoma or adrenal hyperplasia. However, this is a lot to put patients through, to be taking off these layers of medications because of concern that it may be impacting the results of the hyperaldosterone test. And so I think it's important to start with that initial screen for hyperaldosteronism. And then if we need to go back and to do that confirmatory saline suppression test with all the related medication changes, then we certainly can do that. So the initial screen for hyperaldosterone, you do need to stop the mineralocorticoid antagonist, or if your patient happened to be on a direct renin inhibitor. So that part's hard. I've just told you about what an impact the spironolactone and the eplerenone can have on these patients. So if I'm seeing somebody for resistant hypertension, they're not already on spironolactone or eplerenone, I'm going to go ahead and do these labs before I start them on that medication. And we're looking for fundamentally a low renin, whether or not you're looking at a plasma renin activity level or a direct renin concentration, depending upon what your lab uses. Either way, we're looking for a very low renin level, and we're looking for a high aldosterone level, greater than 20 for the aldosterone. And that's going to tell you if you have that very low renin and high aldosterone greater than 20, this is a primary hyperaldosteronism. If you have a low renin, but a borderline aldosterone, somewhere in the 10 to 20 range, it's possible primary hyperaldosteronism. And then we may need to circle back to do that saline confirmatory test. But if you have patients who don't have a low renin, they have a high renin level and their aldosterone level is also within a normal limit, then we don't have to worry about the hyperaldo state. So I think for that initial screen, keep in mind, patients just can't be on spironolactone or eplerenone, which makes sense, or the direct renin inhibitors. And then we're looking to see, do they have a low renin level? If so, our interest is piqued. We're paying attention to that aldosterone level. If it's high, primary hyperaldo. If it's borderline, then we need to do some additional evaluation. So I know that we're just kind of touching the surface of some of the primary hyperaldosteronism. That certainly could be a talk in and of itself. Before we go into our take-home points, I'll just highlight that for patients who I screen positive on that initial screening with low renin and high aldosterone levels, that's definitely when I'm getting my colleagues in endocrinology involved, doing some sort of cross-sectional imaging to see if they have an adrenal adenoma versus hyperplasia. Thankfully, malignant adenomas are rare, but if somebody does have an adenoma that's functioning, there certainly needs to be a discussion about whether or not there is a role for removing that as means of helping to control their blood pressure. If it's that adrenal hyperplasia, then that's really where the treatment with the spironolactone is helpful and why it has such a big impact on their blood pressure for resistant hypertension. So our take-home points in 2017, that cut point for blood pressure was decreased, where that systolic blood pressure of 130 was that new kind of lower limit to say somebody has hypertension. And that timing of when to start medication really depends on that assessment of cardiovascular risk. If patients have known atherosclerotic disease or their ASCVD risk score greater than 10%, we're going to be treating them at that lower blood pressure of 130. If somebody has stage 2 hypertension, we're going to be treating all comers with medications as well as lifestyle changes. And I'll highlight that for the ASCVD risk score, it's certainly imperfect. We use some of these risk enhancing features based on, I believe it was a 2019 update to the cholesterol guidelines. Things like, in particular for women, if you have a history of pregnancy-related hypertension or diabetes, if you have autoimmune conditions like lupus or rheumatoid arthritis, if there's other risk-enhancing features that aren't incorporated into the ASCVD, we don't have as clear of guidance for how to incorporate those risk-enhancing features we use as part of the statin algorithm for blood pressure, but that's certainly part of what goes into that overall assessment. So that number that gets plugged out as we put in their pooled cohort ASCVD risk score is a helpful tool, but certainly needs to be interpreted in that larger clinical perspective that we have of the patient's overall cardiovascular risk. And then just remember those triggers for when to evaluate for causes of secondary hypertension, in particular sleep apnea, and then hyperaldosterone states. And that 3-step approach to resistant hypertension, optimizing the diuretics, using the ACE or the ARB with the calcium channel blocker. considering twice a day dosing rather than just once a day dosing. And then step 3 would be adding that mineralocorticoid medication like Spermolactone or eplerenone. So that's a lot that we've gone through. I hope it was helpful. I know that there are many hypertension experts at your institution, and I have heard just glowing remarks about what a wonderful cardiovascular institute that you have. And I sincerely hope that we have the chance to meet in person in the future. Thank you again for inviting me, and I'll go ahead and pause here for any questions.
Thank you, Dr. Pollak. That was absolutely amazing, just like your cardiology board review talk is. So thank you for lecturing us, and for sure, Leslie Cooper, as I mentioned, and Patty Palika were here a few years ago, and we hope you will come swing down and we can hang out in person when this mess is over. So, Carlos, ¿quieres tú seleccionar qué preguntas? Si quieres, tú las lees en español y yo las leo en inglés. ¿Te parece, Carlos?
Perfecto, doctora Pollak, muchas gracias. Excelente conferencia. Hay ya 2 preguntas en el chat que me parecen interesantes. Doctor Medina, la opción acerca de la polipíldora con dosis bajas de 3 o 4 antihipertensivos para el tratamiento y mejorar seguramente la adherencia de estos pacientes a la medicación.
Right. Okay. So the first question is regarding those polypills with 3 or 4 simultaneous antihypertensive medications to improve adherence. What are your thoughts on that?
Absolutely. I think the polypills, when they have the right combinations of medications, which thankfully most of them do, are fantastic for adherence. I think one of the challenges so in general, 1000% in favor of the polypills. One of the challenges I think can be with titrating medications when you're wanting to have it be twice a day dosing. And so I don't always use the polypills in our patients because I oftentimes am doing dosing that's more than once a day. Certainly you can, depending on how high someone's blood pressure is, still use the polypills for more than once a day dosing. So absolutely a great tool, certainly helps with compliance. I know I personally have an easier time if I'm taking 1 medication as opposed to 3 or 4, and I know that our patients do as well. So it's a great point.
I have a question of my own, and I do cardiac imaging, and I visited a hospital in London, the Brompton, and they have a secondary hypertension CMR protocol, in which they put you on there with the scanner, they do a sinus of the aorta, an angio of the aorta, they rule out coarct, they go all the way down to the renals, they rule out renal artery stenosis, and they also take a look at the suprarenal glands, the suprarenal glands. So I thought it was absolutely fascinating, but I've never seen that kind of proven or tested either in a trial or in a cohort. It's something that just they do. They see secondary hypertension and it's like a reflex. Do you guys have something like that, like at Mayo, or do you think this is something prudent to do?
It's a really interesting protocol, and it's not something that I think has been adopted for routine use. But I think that I'm as a cardiac imager too. That approach really appeals to me. I think that we end up, getting, echoes for patients to rule out coarct, and absolutely, I'm sure we all have diagnosed coarct in patients in their 40s, 50s, 60s, and beyond that was just missed, on physical exam or missed on prior imaging. And the renal artery stenosis is hard because of not always having an impact on patients' adequate blood pressure. But I will say that for individuals who truly have refractory hypertension, that's certainly a patient population, or those who have resistant hypertension where it's still accelerating despite all of the typical medications, where I think there's still a role for treating renal arteries stenosis, potentially even sympathetic denervation. So I think we're really on the cusp of some of these more kind of nuanced approaches to treating hypertension that goes beyond just purely blood pressure measurements in the office. So I really like the Brompton protocol, but we have not adopted that yet here.
Thank you. Carlos, ¿qué pregunta quieres que siga?
Hay unas preguntas interesantes. Primero, en el tratamiento de la hipertensión resistente o la hipertensión refractaria, casi siempre los pasos van incluyendo adicionar diuréticos, digamos, como parte de la estrategia. Hay una pregunta acerca de los efectos secundarios tal vez y qué tan adecuado sería tener una combinación de 2 o 3 diuréticos en la hipertensión resistente. Y al mismo tiempo hubo una publicación reciente del estudio STEP Trial en New England Journal en pacientes de 60 a 80 años, aunque fue un estudio de población china. Queríamos saber cuál es la visión que tiene, teniendo en cuenta que es muy parecido a las estrategias del Sprint Trial. Del Sprint Trial.
Okay, so we have two questions. The first one is related to resistant hypertension and the use of 2 or 3 diuretics. What's your approach to that? Because, start to add up and you can have, worsening hypokalemia. And the second one, it's what your opinion is on the STEP trial and how do you compare that cohort with a cohort of the Sprint trial?
So it's a great question for both. I think that with regards to the diuretics, I tried to streamline the diuretics. If somebody does not have heart failure as part of their treatment of their hypertension, so they don't have HFpEF or HFrEF, then typically for just the hypertension side of it, I'm having them on one diuretic. So I've sometimes find that patients will come for a consultation and they're on hydrochlorothiazide as well as furosemide. And so if I think that for patients who have resistant hypertension, hydrochlorothiazide is just not potent enough. And so I have those patients on chlorthalidone, unless they have that underlying chronic kidney disease, in which case the thiazide-like diuretics are likely not going to be sufficient. And then we just need to use the loop diuretic like furosemide. So I try to streamline, and I certainly know that that Spermolactone and eplerenone have a diuretic effect. In terms of layering things like tramtarine, amiloride, I tend to not use that quite as much. I think because the diuretic effect of the chlorthalidone to me is pretty impressive. And then for our patients who have some degree of heart failure, then certainly layering, depending upon their renal function, metolazone with a loop diuretic for kind of that volume where they're not responding to just a single diuretic. That would be really where I layer it. So I tend not to layer diuretics unless somebody has underlying heart failure.
Okay, sounds good. Carlos?
Thank you. Sí, hay otra pregunta interesante, es que ¿cuáles pacientes, doctora Pollak, definitivamente tú llevarías a denervación renal buscando la costoeficiencia y la costoefectividad del procedimiento?
So, yeah, go ahead.
So for the renal denervation, sympathetic renal denervation, yeah, I am really excited about the future of as we try to adjust this technique a little bit more. I feel like the trials have had older versions of approaches for the sympathetic denervation, and I think there is certainly a blip towards patients with resistant hypertension having a benefit. But it is really kind of muddied waters with our overall approach for this. But I am very interested and hopeful that this will have a potential role with some of the current techniques that are under study for the renal sympathetic denervation. Do you all do much of the renal sympathetic denervation, or what's your practice been like?
I don't think we're doing much, Carlos. Have we been sending patients to renal denervation on a regular basis? I'm not sure about how many, but I don't think there's that many.
Tuvimos la experiencia hace unos años cuando salió el primer estudio de denervación renal en hipertensión resistente y tuvimos algunos casos donde sí podíamos disminuir la cantidad de medicamentos que utilizábamos. Después salió la publicación del estudio, digamos, dando resultados no tan buenos, pero la mayoría de estos pacientes siguieron teniendo dosis bajas de medicamentos. Eso sí, eran muy bien escogidos por un grupo multidisciplinario y creo que vamos a retomarlo en la clínica de hipertensión resistente, digamos, como estrategia, sobre todo para ahorrar medicamentos.
So the experience here, as Carlos was mentioning, is that when the first study came up, there was a lot of excitement about it and started referring patients like on a regular basis. But then the second publication came out, and there was not as striking results. But what Carlos she's mainly a clinician in clinic and in the regular nursing floors, is that when you do the innovation, something that you definitely notice is that there's decrease either in the dose of the medications or in the number of the medications. So there's definitely something positive about doing it. And I think that the more randomized data confirming, hopefully, the result, as you were mentioning, that seems to be very, very exciting. Hopefully, it will be or something else in the armamentarium of treating resistant hypertension. So I don't think we have any more questions, and that's exactly an hour. Carlos, ¿tienes algo más?
No, de pronto la última pregunta para la doctora Pollak es que, digamos, el escenario del COVID y la pandemia nos enseñó, como tú mostrabas ahí, a utilizar la telemedicina, y muchos de nuestros pacientes pasaron de una estrategia muy clínica en el consultorio a la casa, que es más ideal para el control de la presión. Cada vez venden más dispositivos como el watch, el reloj de toma de presión arterial, y muchos de estos pacientes ya nos llegan con un automonitoreo con este tipo de dispositivos. ¿Qué opinión tienes con los dispositivos que toman la presión arterial de pulso en este escenario para, digamos, screening y control de estos pacientes?
So the question is that the pandemic changed everything from education, everything, including, of course, patient care, and the more pandemia, or the longer the pandemia was, more and more patients started using Apple Watch and electronic devices to report the blood pressure. What's your opinion on that remote blood pressure monitoring done by patients? And I guess also the question is how much error would be in those recordings, and how try to sort out what's the best strategy to adapt the current hypertension treatment under that pandemic?
No, it's a great question for certain. I think that the studies that I've seen where some of the wrist wearables for measuring blood pressure can have about a 5-point difference compared to what we're seeing in the office. So it can be very accurate. I would say that those in practice, I've found that those error bars are a little bit wider than that. And so I tend to have patients of mine who want to use a wearable, particularly the one that's their wrist for the blood pressure. Kind of prove to me that it's aligned with what we have in the clinic. So I'll have them wear it and come in to have a nurse visit with the blood pressure check, or have them do it against an upper arm blood pressure cuff that they have at home to make sure that we're getting those readings that are concordant. I think it can really be helpful. I would say that one of the challenges for us is with the patients at home with the pandemic. We get a lot of information, a lot of messages and data, and I think we're still figuring out in our practice what's the best way. How do we have kind of a case manager of a nurse to kind of filter through some of these messages with the data, and then have some algorithms for responses that go back, so that way we don't have an inbox of so many messages, and can get back to patients in a timely manner with feedback that helps control their blood pressure. So I think finding the ways to optimize that connectivity for patients based on the data that they have at home, and then getting real-time feedback from the providers, I think will continue to be an important area to evolve for all of us.
Okay, and we have a final question. I know it's already after a couple of minutes after 2. Our CCU director is asking about what's your opinion about the STEP trial, and if it's making a difference in the way you approach these patients.
So the STEP trial, in terms of the management with for the blood sugar side of things,
yeah.
I think that it's certainly, I don't know that I've seen data to support the huge impact on the blood pressure from the STEP trial, but I think as it's controlling those cardiometabolic risk factors, and to the extent that that will help control blood pressure, I can say I haven't applied the results in terms of adding that medication to many patients yet, but I think that that is certainly one of the tools that we need to talk about, particularly for individuals who want to be more aggressive. I think there's that balance of how many medications for folks to take for, in particular, primary prevention for increased cardiovascular risk factors. So I'd say that I haven't done widespread application, but am certainly interested anytime we can show an improvement in those cardiometabolic risk factors.
He's clarifying here, it's about patients between 60 and 80 years old in which the goal is less than 130. You know, when you're approaching to that octogenarian and you're a little bit afraid of you know, falls or, you know, pre-syncope and whatnot, how aggressive are you with that particular set of patients?
Oh gosh, I was thinking that we were talking about the semaglutide. That was the study that came out for the metabolic syndrome that came out in New England Journal. That was also being called the STEP trial. But so with the older patients, I think that it really needs to be individualized because of the risk for the falls and the acute kidney injury and hypotension. And so I certainly do not apply you know, one size fits all for blood pressure goals for patients who have known cardiovascular disease or who are at high enough cardiovascular risk, because the data is limited for individuals over age 75. And I think that we'd all agree that there's patients who are over age 75 who are very robust and want to really be aggressive in lowering their blood pressure to do everything possible to reduce events. And other patients who we're just going to likely expose them to risk of side effects from the low blood pressure without likely making a big impact on events. So I think more so even than the younger individuals, those age 75, I really am doing a patient-centered decision making and not just applying an algorithm, because I think it's not clear what the overall risk versus benefit is.
Okay, thank you. Thank you so much, Dr. Pollak. It was amazing and incredible to have you. I'm also getting a lot of compliments about your slides, which are truly impeccable. So thank you for an outstanding presentation. And as I mentioned, hopefully we'll have you, Leslie, and Patricia Pelliga come back, well, you for the first time here in Colombia in the near future. Have a great afternoon, everybody, and thank you again, Dr. Pollak.
Thank you. Bye-bye.
Bye-bye.